Thank you very much, Mr. Chairman. It's a tremendous honor to be able to present this data. I have to thank the organizing committee for inviting me and also the editors for JAMA for helping to further improve our paper and eventually publishing this. I'm standing here on behalf of my co-investigators, and I will thank them at the very last slide. So the STOP-AKI trial was a sepsis trial of alkaline phosphatase in acute kidney injury. And this trial was a randomized, double-blind, placebo-controlled trial with 4 arms, parallel groups, and it was a proof of principle trial, dose finding, and we had an adaptive design in choosing the optimal dose. So this was a phase 2A, 2B study. The steering committee, apart from myself, was formed by Ravi Mehta from the United States, Pat Murray from Ireland, and Michael Ioannidis from Austria. We had a DSMB that was chaired by Professor Andy Shaw, and we had an adjudication committee that was chaired by Professor Bruce Molitoris. Both were from the United States. The trial was conducted from December 2014 until August 2017, and we had 53 recruiting sites in 11 countries, as is depicted in this picture. So about the background. We have to realize that acute kidney injury happens in up to 60% of ICU patients. And the severity of this AKI is related to their outcome. But even if you survive your AKI and ICU stay, there is a drop in longer-term renal function. And even though it seems that it's restoring, you actually have used up your renal reserve. And we know now that if you follow up patients for a longer of time, that those patients that need renal replacement therapy for a short period of time in the ICU are much more likely to have end-stage renal disease after 2 years, up to 10% following 2 years of follow-up. So this is a huge problem. It's a burden to the patient, and it's a burden to society as well, as end-stage renal disease is an expensive problem. So that's acute kidney injury. Nevertheless, there's no drug license to prevent or treat acute kidney injury, and all we can do is give the patients renal replacement therapy. Now, as everybody knows here in sepsis, endotoxin, for example, is recognized by its receptor, and then a cascade starts and cytokines are produced, and this is related to shock and multiple organ failure and death in sepsis patients. Now, the interesting thing is that if endotoxin that has 2 phosphate groups is seen by alkaline phosphatase can remove one of those phosphate groups. And then endotoxin is still attached to its receptor, but the whole inflammatory cascade will not happen. And more so even, while this is on the receptor and not inducing the inflammatory cascade, it actually works as an antagonist for other mediators that are recognized by the same receptor. Moreover, during sepsis, we know that ATP is released from cells. And when ATP is extracellular, it's a pro-inflammatory compound by itself. And again, alkaline phosphatase is able to remove phosphate groups, forming ADP, forming AMP, and eventually producing adenosine. And adenosine by itself is anti-inflammatory and tissue protective. So the alkaline phosphatase that we measure routinely in our patients as a measure of liver function, we have to realize that this is actually an enzyme that is detoxifying different compounds, and it does so by removing phosphate groups of these compounds. So if you would administer alkaline phosphatase to patients, it might be beneficial because of this action of the enzyme. So based on animal experiments, actually, in the early 2000s, 2 small phase 2 studies were performed with the bovine alkaline phosphatase from intestinals of cows. In the first study, it was done in sepsis patients only, and in the second study, it was done in sepsis patients with signs of early AKI. And what we found in those small studies, it were only 36 patients per study, was that indeed those patients that were treated with the alkaline phosphatase, the improvement of endogenous creatinine clearance was more pronounced, less people tended to need renal replacement therapy, and if they needed it for a shorter period of time. And so this was the combined endpoint that was statistically significantly influenced to the benefit of the patients by alkaline phosphatase. So based on these experimental trials in small groups of sepsis patients using the bovine alkaline phosphatase, the company decided to produce and develop a human recombinant alkaline phosphatase. And they did this in a clever way. There are 4 isoenzymes in the body of alkaline phosphatase. And the first one depicted here is the intestinal alkaline phosphatase. And that is the alkaline phosphatase with the highest biological activity. There's also alkaline phosphatase expressed in the placenta. And the placental alkaline phosphatase has a lower biological activity, but is the one with the longest half-life. So the company found that they could use the catalytic compound and the crown compound of these enzymes, and so they combined that, and therefore the recombinant alkaline phosphatase was very active and at the same time had a long half-life. The trial design of the STOP-AKI study was as follows, and it was published in the British Medical Journal Open. So we had patients with a diagnosis of sepsis and AKI and assigned informed consent. And then in the first part of the trial, patients were treated with 3 doses of recombinant alkaline phosphatase or placebo. And we enrolled approximately 30 patients in this phase. Then, in the second part of the trial, the DSMB chose the optimal dose of alkaline phosphatase, and then the trial continued with this dose and placebo. So that was the adaptive part of the trial. How did we come to those doses? Well, we learned from in vitro work and animal testing that the optimal trough concentration that was associated with the beneficial effect on the kidneys was, as you can see here in the dotted line. And so the lower dose was chosen on purpose to be below that, to see if this lower dose could also be effective, yes or no. The middle dose was chosen so that the concentration would stay above this minimal effective trough concentration during the 3 infusion days. And then the high dose was chosen to be above that much more, and so that it would stay above that trough concentration for a full week. And just mind you, these are alkaline phosphatase concentrations that are reached in these patients. So it's 10,000, compare that to the normal endogenous values that we normally see in patients. So it's a really high dose of alkaline phosphatase that is in the bloodstream of these patients. The timelines of the trial was as follows. So we called day 0 the pre-screening, screening, and baseline day, and the moment the drug was given was called day 1. So patients were treated for 3 days, and we focused on day 1 to 7, and we measured endogenous creatinine clearance each day, and I will come back to that in the next slide. Secondary endpoints were also endogenous creatinine clearance for up to 28 days, the incidence of renal replacement therapy, and also longer-term effects were major adverse kidney events and mortality up to 90 days. So about the primary endpoint. So what we did was we measured endogenous creatinine clearance every day. So we collected urine for 6 hours on the same moment every day. And we used a normal calculation to calculate the endogenous creatinine clearance. So we did simulation and we found that we would have 80% power to show a positive effect of the drug and that the creatinine clearance would be 19 millimeters per minute higher in the active group compared to placebo. And we used the area under the curve as I will show you here. So for example, there's an increase over time of the endogenous creatinine clearance in a patient during the first 7 days. And we would then use this area under the curve as a total measure of this improvement in renal function. We included the usual suspects. So this was informed consent, adult patients. They needed a sepsis diagnosis within 4 days of the AKI diagnosis, and AKI should not be there longer than 24 hours. The exclusion criteria were also the usual criteria. I want to highlight two things. Many people ask me. Urosepsis patients were also excluded because in urosepsis, the increase in creatinine is many times related to obstruction, and so it's a different mechanism of action compared to other sepsis-associated AKI. And we also excluded patients that were already on or were thought that they would need renal replacement therapy within 24 hours because this was a relevant secondary endpoint. So following a pre-screening yield, we ended up with 301 randomized patients. This was an intention to treat trial, and we had follow-up. So this is the first part in dark blue and the second part in light blue. And as you can see, we ended up with the highest dose for part 2 for the second part of the trial. As this was the first trial in which a recombinant alkaline phosphatase was administered to septic patients, safety was also a very important endpoint. So all the patients that received any dose of alkaline phosphatase were added to the safety data set. And then for the efficacy endpoints, we had an intention to treat population, and we had few people lost to follow-up. This is the table 1. And the groups were pretty much balanced. These were very sick patients, so the Apache score was around 26. We had 60% of patients on mechanical ventilation, about 90% of the patients in shock. The groups were fairly balanced, except slight differences in renal function. So as you can see here, it's a small difference, but creatinine clearance was a little bit lower in the active group, and as a consequence also the staging of AKI was a little bit different. And to make this more visual, the mild AKI, there were slightly more patients in the placebo group, and the more severe AKI, stage 2 and 3, were more patients in the active group. And I'm highlighting this because it might be of relevance for the results later on. So the first part of the trial was the dose finding part. So we calculated the area under the curve, and we divided that by 7 to have a number that would say something. So on average, in that first week, the patients had a creatinine clearance in the placebo group of 46 mL per minute. It was similar in the 0.4 group, and it was tended to be a little bit higher in the 0.8 and the 1.6 group. These differences were not tested. They were just used to decide what dose would be used in the second part of the trial. So this was done by the DSMB, and following the rules that they should, it was said that with a similar efficacy signal and no problems with side effects, the highest dose should be chosen, and that's what they did. But importantly, this was still blinded to all the research personnel. So we did not know in the second part of the trial which dose was chosen and with which dose we were continuing. So this is the safety table, and it's a large table, and I will not bore you going through it. Importantly, the number of adverse effects was similar in all groups. There was no dose dependency signal of any side effects, and also very importantly, we found no relevant increase in antibody formation against the recombinant alkaline phosphatase. So I will not bore you with that, you can see it in the paper. However, we also looked at fatal SAA, so the serious adverse event. So by definition, if a patient died, this was reported as a serious adverse event. So over time, in the placebo group, we had about 30% of patients that died. Interestingly, in the 0.4 group, it was similar. It looks like it's lower in the 0.8 group, and again, in the 1.6 group, it was lower. We did not do any statistics on this because it was a safety endpoint. However, I will come back on this later on because mortality was also a secondary endpoint. So the primary endpoint was improvement of renal function over the first 7 days. This is the median value of those that were treated with placebo, and so the area under the curve was used as the primary endpoint. And you can see a normal course of improvement of renal function. This was the improvement in the active group, And while it looks like it's a little bit better, the area under the curve was completely similar, and so the primary endpoint was not met. The primary endpoint was negative. As exploratory secondary endpoints, we looked at longer-term renal function. So again, creatinine clearance was measured up to 28 days. This is the placebo group, and this is the group with the alkaline phosphatase treatment. And if we do statistics on this total time-dependent effect from day 1 till day 28, it is a significant improvement in the group that received recombinant alkaline phosphatase. And post-hoc studies of post-hoc testing shows that this is mainly due to the effect on day 21 and day 28. The difference in renal function that we found here did not translate to a difference in renal replacement therapy. So this was another secondary endpoint, and there was no signal of improvement at all. We had major adverse kidney events on day 28, day 60, and day 90. There was no difference between treatment groups on day 28. On the right, you can see how we a priori defined these MAKEs. On day 60, there was a significant benefit by recombinant alkaline phosphatase, and the same was true on day 90. So, and I must also add that this improvement was mainly driven by the difference in survival. And this was, as an exploratory, again, secondary endpoint, the probability of survival over time. So in the placebo group, we had a 28-day survival mortality, of 27%, and it was 14% in the active group. This was statistically significant on 28 days, and this statistical significance persisted up to 90 days when we tested it. So we were surprised by this large beneficial effect on survival. So what we wanted to do is to check post-hoc if there were any other reasons to explain this effect. So what we did is 2 post-hoc multivariable analysis. First, we looked at organ dysfunction. So per organ system, per point, you can see there's an increase in the hazard ratio to die. So if we put that in a multivariable analysis, still treatment with the alkaline phosphatase was significantly associated with better survival. And we also did a forward stepwise approach with multiple variables. We tested 15 variables that are associated with outcome, including mechanical ventilation, vasopressor treatment, disease severity scores, etc. But still, and from that analysis, we found that Apache score, initial endogenous creatinine clearance, and time to treatment were significantly associated with outcome, but still also treatment with recombinant alkaline phosphatase remained a significant predictor of good outcome. We looked at a priori defined subgroup as well, and we measured inflammatory biomarkers, and we measured tubular injury biomarkers in the urine, and we looked at time between AKI diagnosis and start treatment, and we found no influence there. So we could not dissect out a specific subgroup that benefited more of the recombinant alkaline phosphatase. We also looked at the baseline renal function and how this influences the outcome. So this is another way to show the data. So the red line above is all patients with placebo and treated patients that had a baseline creatinine clearance above 60 mL per minute. And the blue line is all patients treated and placebo below 60. And you can see to what extent impaired renal function influences the prognosis of these patients. So if we look at the therapeutic effect of those patients with a baseline creatinine clearance above 60, there's no therapeutic effect of recombinant alkaline phosphatase whatsoever. While if we look at the patients with impaired renal function at baseline below 60, the clinical benefit of recombinant alkaline phosphatase is clearly there. So the discussion of our data is that what could be possible explanations that we did not see an effect on the primary endpoint, the creatinine clearance over first 7 days? Well, first of all, one could say the compound is not effective. I don't think that is a possible explanation because we found all these other effects and longer-term effects as I showed you. One thing is that we found this mortality difference, and this could actually backfire to the primary endpoint. So patients that were saved in the active group, barely surviving, might have a lower renal function, and so they bring down the mean renal function compared to patients that died in the control group, and this could be an issue. There are many things you can say about creatinine as a function of renal function, as a measure of renal function. And the thing is, there's no other generally accepted measure of renal function that is feasible to use in a trial like this. But it's late, it's insensitive, so that could be a reason as well. And the imbalance, the small imbalance in renal function at baseline, this is also from data of this trial, showing that if renal function is just maybe 10 mils per minute less, the chances of dying are doubled. So there's a huge influence of renal function on outcome. And even so, with the worse renal function in the alkaline phosphatase, there was still the benefit. So that is also suggesting a real effect. And maybe 7 days was too short, because the effects that we found did become significant later on. So my conclusions are that recombinant alkaline phosphatase was considered safe and well tolerated. We had no safety signal whatsoever. It did not affect short-term renal improvement, and this was the primary endpoint. So it's a negative study on the primary endpoint, and I want to emphasize that. However, we had exploratory secondary endpoints, and we did find statistically significant improvements of longer-term renal function, on major adverse kidney events, and survival. So, on behalf of my co-authors and the co-investigators, I want to thank you. I want to thank the people of AM Pharma, and I want to thank Pleun Hemelaar, Anneliese Reesink, and Willem Radboud that are not on the paper but did a tremendous amount of work. Thank you very much.
Congratulations for this very complex study. Open for the questions and comments.
Peter, I'll make a comment, and Massimo may have a question. So, as you can imagine, studies like this pose a struggle for us. It's a 2A, 2B study. We'll publish about 85 clinical trials this year, of which about 10 will be labeled 2A, 2B, or exploratory, or preliminary studies, because they're not governed by the 2A, 2B system that's familiar to people. So we'll publish about 10 of the 80 or 85 papers will be preliminary or 2A, 2B. We're selective when we do it. You know, the paper may not be well cited, but the issue for us is our commitment to do science and physiology. And so, you know, a half a dozen times a year we want to publish something that may portend what the future looks like. And that's the issue with this compound. What will it look like after larger clinical trials that are more focused? So, Peter, what's the next clinical trial?
Yeah, so we think that this is a signal that cannot be ignored. So we are designing a phase 3 trial. I think we wanted in this phase 2 trial to have mechanism of action, and that was the reason why we chose the short-term renal function. But for patients, long-term renal function and survival is much more important, of course. But we didn't have the nerve. But for the next trial, I think it's a phase 3 trial. We will do it again, similar in design, adaptive, up to 1,500 patients we are planning, and with mortality as the primary endpoint.
Hi, the question may be naive. Do you believe that other indicators, such as the NGAL, could have been exploited, or did you measure it in your sample?
Yes. Well, actually, I went over that quite quickly, but we did measure NGAL and KEM1 as tubular injury markers. We also measured a few cytokines and PCT as inflammatory mediators, because a priori we thought maybe we can dissect out a specific subgroup that might benefit more than another group. There was no, so the beneficial effect was overall grouped similar. The only influencer of outcome was baseline renal function. So in the phase 3 trial, we will focus on patients with a baseline creatinine clearance below 60.
Thank you.
Yeah.
Thank you, Peter.
Thanks, Max.